Oh, good morning, everyone. Thank you so much for having me, and thank you to MMDC for sponsoring this, holding this event, and for DTE for sponsoring it for us. I'm going to warn you, I'm really passionate about the subject of healthcare. I've had the pleasure of meeting many of you, so you probably are already wondering how long is she going to talk and how fast is she going to talk. So I'm going to try to stay back here with my notes behind the podium, but if I grab this mic and start walking around and leave my notes behind, Don Schur will probably stop me. He's on our hospital board and he knows. So, or any of you can tackle me and tell me slow it down. So I'm really excited to talk to you all today. I know what you really want to hear about is what's happening here in Clare, right? That's what you really want to hear about. I need to give you some context though, and of course this is an economic forum, so I need to talk about economics as well. So you can see behind me the key points that I hope to cover with you today. I'm going to try to do the first part as quickly as possible, but make it meaningful, because you are all business leaders, you are community leaders, and you are consumers of healthcare. So having some context about what's happening in our industry and how that affects the economics of our communities and your health of this community is really important. So, whoops, sorry, I think I went backwards instead of forwards. I'll get the hang of this quickly. I never want to assume that everybody knows what MyMichigan Health is. We are a not-for-profit health system, and we're really proud of that. We are also purely serving rural Michigan. Pretty much anything north of I-96 is rural, right? And you can see our footprint behind me. We are very proud that we are serving communities from Sault Ste. Marie all the way down into Midland County, Bay County, down to Gratiot County. The area that I'm responsible for is really from Houghton Lake south to Gratiot County and the miles kind of on either side of 127. That 127 corridor really serves us well in healthcare. We've been recognized for a lot of things. What those really are saying to you is that we are recognized by external parties that look at not only the quality of the care we're providing in these communities, but also our business practices. And that's what all of those awards that are listed up there represent. We're really proud, and I want to make sure you all are aware that in 2021, the hospital here in Clare was named a top rural hospital in the United States of America. That is an amazing accomplishment in the middle of the mitten. Oop, thank you. The other thing that isn't on that slide, because it's kind of breaking news, is for the second year in a row, our health system has been recognized by Forbes as a top rural health system, as a best employer. And that's not just in healthcare, but that's all industries. So we're really proud of that as well, especially coming through COVID really decimated us as an industry, both in terms of our resiliency as a workforce and financially. So that we're still standing out as a health system, as a great place to work, really speaks volumes to the quality and the excellence that we stand for. Whoop, I'm sorry, I will get the hang of this as we go. So let's get to the context. Why is rural healthcare important? You're probably already thinking, of course, saving lives, keeping us healthy and all that. I'm trying to keep it simple. There's really two things, economics and saving lives. And we're going to talk about economics first. There's an infographic on the screen that comes from the Michigan Hospital Association. It's their 2023 Economic Impact Report. And you might be surprised to notice what's in that round red circle, that healthcare is the largest private sector employer in the state of Michigan. When people think of healthcare, they tend to think of giving and receiving, not of an economic engine. It drives me crazy, and Jim knows this, that MEDC does not consider healthcare as part of economic development when we are the largest private employer. The way we look at it at MyMichigan Health, and this informed our most recent strategic plan, is when we look at our campuses, especially where we have medical center campuses, we are usually the largest employer in that county. And if we're not the largest, we're usually within the top 1, 2, or 3. So not only are we important to be in the community to provide healthcare and access to healthcare and lots of services, but we're also providing jobs. And people, where they work, they spend, they consume, right? We hope they come to live in the communities where they work. So they're putting kids in schools and paying rent and buying houses and paying property taxes. So we recognize as we do our strategic planning, our core is to deliver healthcare. But we never do that without being cognizant of the fact that we are providing jobs in these communities, and that is a big part of your economic foundation. So if our services ever shrink, we don't have enough volume, we can't grow, not only are we providing less health care, we're also providing fewer employed people in the community, and that can hurt the economic base. So we're always very cognizant of that. So saving lives, we'll switch to that now. Oh, I think I missed a slide again. There we go. I'm not going to go through all of this slide. There's a ton of information on there, and it actually comes from the Michigan Hospital Association's Community Impact Report. But when I laid the economic report and the community impact report side by side, they really cross over, because all of the things you see listed there under promoting health and wellness and caring for patients all have impacts on both sides of that equation, both in providing care, saving lives, but also in the economics. The one I'm most proud about is the community building activities that's down in the lower corner. That's not really about healthcare. That is us as healthcare workers living in these communities, also giving back and recognizing that it takes a lot to make a community vibrant. So I hope you're noticing MyMichigan Health walking in the parades and sponsoring events. We pay our employees to volunteer. So we're hoping you're seeing more and more of our employees out there volunteering, because we recognize it takes all of us to create a vibrant community. The caring for patients side really gets into the finance side of healthcare, and it's a morass, it's a black hole. I've worked in healthcare for more decades than I can count, and I still cannot tell you how we get paid, quite honestly. So we'll save that for another day. But what we're always trying to solve for is that the majority of our patients are insured by either Medicare or Medicaid. The vast majority. Those are government payers. So there's not a lot of influence we have in what we get paid for the care we provide, and what we get paid by the government does not cover the cost of care. So think about that. You're all business owners, you're all employees. Think about working in a business where you're providing a service or a product, but what you're getting paid does not actually cover your cost. That is the reality in healthcare, not just in not-for-profit healthcare, but all of healthcare. So now let's talk about saving lives. And this is where I get really warmed up, because this is why I'm in healthcare and why all of us who have chosen healthcare occupations are in it, because it is a tough business, as you can see already. So obviously we are here to save lives. So let's talk about being the only source of healthcare in rural America. Typically, you go to an urban setting, there's lots of healthcare providers of all shapes and sizes, and you have choices and options, and there's lots of access points. In rural America, there are fewer and fewer access points for healthcare, and it's usually the hospital and the hospital system, if you have one in your county. I didn't put a map here from the American Hospital Association, but if you looked at the map of where hospitals exist in America these days, you would be shocked to see the gaps. We're lucky in Michigan, we don't have a lot of gaps, but the further west you go, the fewer hospitals they are, and the further people are going for care. We are always the only source of 24/7 healthcare. We are always open. We never turn anyone away, regardless of your ability to pay, regardless of what kind of needs you have. You come to us and we are going to take care of you. We are a safety net and often the only source of care. And then time and distance. I think we all know the further you have to travel for something, the more time it takes to get there. Time and distance is a direct impact on the health of a community. In an emergency, time and distance is life-threatening. You've probably heard of the golden hour in trauma care. When someone is traumatically injured, science has shown us we have about an hour to produce life-saving care to help that patient get a good outcome. If you're having a heart attack or a stroke, the longer it takes you to get to where we can start getting that blood supply going again, the more heart muscle you lose, the more brain tissue you lose. In obstetrics, we have a 30-minute window. From the minute we decide a woman is in an obstetric emergency, we have 30 minutes from making that call, that decision, to the incision that gets that baby out to save both of those lives. So having hospital-based health care within no more than an hour is really important. In most cases, it's 30 minutes. And then, of course, just in general, when you think about all the things you have to do in your life, getting your annual checkup, getting mammograms, having everybody's favorite colonoscopy that we expect you to do over 40, right? All of that takes time away from work, time away from things that are fun to do and things that you need to do. So the further away that healthcare is, the more likely people are not to get it. And that's just in general. Then we look at our populations that are impoverished. They may not have the transportation to get to healthcare at all. And studies have shown that, and I'm getting a little ahead of myself, people in poverty are not motivated to get healthcare. And we'll talk about that in a little bit. But so in a life-saving situation, we've got to get you to an emergency room. On an ongoing basis, to keep you from needing emergency rooms, we want to keep you healthy. So you need access to care that's nearby. The map of Michigan that you see there that's different shades of blue, that is a map that is showing the health of each county in the state of Michigan, 1 being the best, 83 being the worst. The easy way to interpret that map is just to know the darker the color that you see there, the less healthy that community is. Can you spot Clare County? Pretty dark blue, right? Yeah. At the time I printed that map, we rated 79 out of 83 because we have a lot of dynamics in our community, not unlike many other communities, that are getting in the way of people getting great health care. I put this map up because in 2019, we were looking at it at the same time we were looking at our next strategic plan. And if you remember our footprint from that very first map I showed you, if you can remember that and compare it to that map, we were absolutely stunned to see that while we're getting all these awards for great healthcare, we're measuring all these outcomes, the communities that we're providing healthcare in are some of the least healthy in the state of Michigan. And we recognize it's because we're not reaching everybody. And we had an existential crisis in a moment where we said, are we going to be okay with saying, look at all the awards we get, look at the great outcomes we're producing for patients? Or are we going to change our focus and get out there and get these communities to be healthier? And we decided that that's the road we're going to take, the road less traveled. It's going to be the work of a generation, and it's going to take all of us to do it. But that's what we want to be about at MyMichigan Health. And that circles back to why we're so committed to rural healthcare despite some of the challenges that we face. The other infographic that I put up there is from American Hospital Association, and it speaks to the challenges in rural healthcare and the number of hospitals in rural that are closing. Rural hospitals are closing at a much faster rate than most other businesses. Many of those hospitals, if they remain, they're reducing services. They're not doing surgeries anymore. They're not doing inpatient care anymore. Changes like that are going on in Michigan around us right now. It's not what we're doing in MyMichigan Health, and that's the good news for the Clare story that we're going to be getting to. So care close to home. That's something you hear us say in our line of work all the time. MyMichigan Health believes in care close to home. If we're not providing that access to care near where people are, for all the reasons I just mentioned, people aren't going to get that care, and they're going to be unhealthy, and we're going to continue to see outcomes in the state of Michigan that we see right now. So what are the challenges in rural health care? Well, one, the population is not as big, not as plentiful, not as dense. So when you don't have people close together, it's hard to get everybody to health care. When there's fewer patients to serve, and you all know this from your businesses, there's a point of efficiency where you have volume to match your resources, and you hit that sweet spot where you can generate a margin. When there's fewer people to serve and they're spread out, it's very hard to aggregate enough volume to be able to make ends meet. The populations in rural America tend to be poorer. They tend to have less insurance, if insurance at all, and less inclined to seek health care proactively. If you're interested in that topic, that's one I could talk about for an hour, not today. But there's a great book called Bridges Out of Poverty that talks about what happens to people in poverty class and how they're different than middle class and upper class, and why they think the way they do and what obstacles get in their way. And if we're trying to design businesses to reach those people, we're trying to employ them, or we're trying to help them be healthier, we've got to understand where they are so we can figure out how to help. And Bridges Out of Poverty is a great book for that. And I think we all relate to the fact that it is harder to recruit people to rural America, isn't it? And I don't know about your businesses and ours, it's also hard often to get the supplies and the services that we need. We own a lot of hospitals, Alpena and the Upper Peninsula, and we are struggling to get a linen vendor just to provide our gowns and our sheets and our blankets, for example, because there's not a lot of business up there, so people would rather focus their businesses downstate where there's more density to serve. What is really, I think, particularly special and very unique about MyMichigan Health is how we structure care so that we can keep it close to home. So I put two images up there, and you're probably wondering what they have to do with each other. One's a wagon wheel and one's a molecule. And I'm using those to give you a visual of how healthcare can be structured. Most healthcare systems are structured like a wagon wheel, where at the center they have one big hospital we call the tertiary hospital. And at the end of the spokes are small hospitals that we call critical access. And their job is to be the emergency room and the primary care provider, but then surgeries and admissions and things like that go to the mothership. So small hospitals out on the spokes, moving everything into the center. For us and our philosophy, that's not care close to home. For us, we see that as an impediment to people getting the care they need. So we've designed our system more like a molecule. We have a tertiary center, and that's Midland, but we surround our tertiary center with community hospitals. And I would submit to all of you that for most of us, all the care we will ever need in our lifetime can be delivered in a community hospital. In tertiary hospitals, we take care of complex trauma. We take care of brain surgery. We do emergency heart procedures. How many in this room really hope to encounter any of those three things in your lifetime? Right, we're all working to avoid that, right? We here in Central Michigan, with what we've arrayed in terms of healthcare services and access, can provide almost all the care people are going to need. And if you get into one of those very serious conditions, that's why we have our Midland Tertiary Hospital and why we are aligned with University of Michigan, so that we have what's called quaternary care. So we look like a molecule. So in a wagon wheel type of health system, they might deliver babies only in one spot, and that's the center. They might do orthopedic surgery only in that one spot. For our health system, we've created nodes, and all of our hospitals provide community care as well as specialty services that are appropriate for that facility. So we deliver babies in Alma and Alpena and Midland. We do critical care in West Branch and Alpena and Midland and Alma. Alma is the largest behavioral health inpatient unit in our health system. It's also our accredited inpatient rehab service for people who are recovering from strokes, for example. Here in Clare, yesterday, we just admitted our first patient to a new service that's called medication-assisted detoxification. So for people who are trying to overcome their addiction, but the symptoms keep getting them and that the discomfort of the systems cause them to go back and use again, they get to a point where they're stable enough and they're committed enough that we can bring them into the hospital and use medications and monitoring to get them through that detox period. And they can emerge from that clean. And then those symptoms are not there. Thank you. We have been trying to get that going for almost 18 months. And again, our first patient yesterday. So we've got some bugs to work out, but it's really important for us to do that here in Clare based on the demographics around us. That's why we chose to put it here and not Midland or Alma or someplace else. So another point I have down there, and it's highlighted in yellow, is we believe in care close to home, provided we do it enough to do it well. So I mentioned obstetrics on purpose a couple of minutes ago, and I was looking to see if anybody went, at me. Because probably the most common question I get before we announced the rebuilding of the hospital was, are we bringing obstetrics back to Clare? And the answer is no, because we have to do things well enough to do them well. So with obstetrics, you need to be delivering lots of babies so you experience emergencies on a regular basis so that you have an expert team that knows what to do in an emergency. I mentioned earlier there's 2 lives at stake in an obstetric emergency, the mom and the baby. And if you don't see an emergency but a couple times a year, you're not going to be equipped to handle it as well as people who do it all the time. So that's why MyMichigan Health has aggregated just a couple of hospitals where we do deliveries, because we can do enough deliveries to have that experience. So all of our deliveries for Central Michigan are in Alma. We are around 500, 550 deliveries a year, and that's enough for us to see an urgent situation at least once a week and a true emergency every 2 weeks. So that team knows what to do, and that's what you want in those situations. So that's part of how we design, why we decide what's care close to home and what shouldn't we be doing, because we can't do it as well as others where they have more volume. So this is a picture, and there's also a copy of it on your table if you want more detailed information. This is how we've designed healthcare specifically for Central Michigan. That is showing you Harrison, Clare, Mount Pleasant, and Alma, all arrayed up and down 127. All of those points are about 15 minutes apart, and if you're going from Clare emergency room to Alma, it's exactly 30 minutes, and I know it because I drive that almost every single day. And it's important in terms of designing how we provide care. That configuration is what allows us to provide all the care that you need as close to home as possible. That configuration creates redundancy. So if you work in Clare, but you live in Mount Pleasant and you need a service, you can decide which place works for you for that appointment. Are you going during your workday? Are you going after hours? That redundancy also helps us. Somebody in the room was telling me a story about a piece of equipment that broke in Mount Pleasant and they needed a service there. That does happen, unfortunately, but we offer that service in Clare and Alma as well. And that worked for that person. And we moved the staff and we moved the patients and we continue to provide those services. So there's a lot that is going right in healthcare right now, and there's a much longer list there on what's working than what's not. Partly because I wanted this to be a really positive conversation too. But you can see all the things we're doing, and I would love to tell you about every single one of them because they are life-changing for people. But a couple of things I'll highlight on what's working: 24/7 access to testing. When people go to the doctor and then your doctor says, I need you to get this lab drawn, I want an x-ray, and I want all these other things, we're offering as much as we can 24/7. People can, we prefer they make an appointment, but they can just walk in and get that service. More and more things that we can't do 24/7, we are doing into evening hours and weekend hours because we need healthcare to be efficient and accessible for people so they'll get it. I'm really thrilled that we are doing hospital at home. We are probably one of the only rural healthcare systems providing a hospital level of care for patients in their homes. And that's really important for saving money for patients, saving money for the health system. And face it, when you don't feel well, do you really want to be undressed in a dressing gown with your door open with the public walking up and down? No. You're going to heal much better at home with your remote control, your cat on the bed, your own jammies, and your own food in some cases. So it's good all around. It only happened because of the pandemic. The government let us do hospital at home to keep people out of the hospital when we needed those beds for COVID patients. We learned it works, and now we're getting waivers and approvals to continue doing it. Our hospitals are extremely full right now as well, which is stunning. It's not COVID anymore, but we are busier than we used to be pre-COVID. People are sicker. We don't know why yet. Research will show us why that is, but people are sicker, and we're holding census in Clare and Alma where we do inpatient care kind of at the level that we would see in flu seasons before, and that would last like 2 weeks and be done. But we are constantly full. So the fact that we can take 10 or 11 more patients and care for them in their homes, that's 10 or 11 patients that wouldn't have a hospital bed in Central Michigan because of the demand that's there right now. School-based health clinics, we are starting to put clinics into the schools so that kids, maybe their patients aren't taking them for care, or it's hard to get away from work to get your kid to their wellness exam, things like that. We can do that right in the school system. We provide transportation assistance for those people who can't get to their appointments. And lastly, I just want to highlight the discounts. We discount our bills for people who have difficulty paying, and I've highlighted in yellow what those discounts look like. So you can see that they're significant. So it kind of goes back to the financial story. Medicare and Medicaid don't pay us what it costs to take care of patients, and we are dramatically discounting our costs for people who can't afford health care because it's so important that people get that health care. So in the middle of all that, we have to make ends meet somehow. So what's not going well? I think we'd all say the dynamics in the workforce right now, having enough people to staff what you need. For us, it's particularly physicians, being able to find enough physicians. The U.S. medical system is not creating enough physicians to meet all of our needs, and it's even harder to recruit into rural. So we are constantly looking for that sweet spot. We're all in healthcare because we want to do the right things. We really don't care about getting paid. We just want to take care of you. And then the business side kicks in and says, you know what? The nuns in Catholic systems used to say, no money, no mission. What we say now is no income, then we can't produce outcomes. And the outcomes we're trying to produce are healthier communities. So all that is context for what is going on here in Clare. So we are here to stay. And I'm going to flip over to my notes just a little bit so I stay concise on this, because I have a feeling you're going to get more out of asking questions than me telling you our story. So we announced in July. We made the decision about a month earlier than that, but we didn't want to make the announcement till after 4th of July because we figured everybody would be out of town. We announced that we are here to stay. That has been an incredibly long journey for us. You look at the age of the hospital, and we should have replaced it long ago. And I give a ton of credit to Ray Stover, my predecessor, because he was working very, very hard on that right up to the end of 2019 when he had to hand the keys figuratively over to me. It was a really challenging journey to figure out how to get from where we were to where we are. And then we have COVID interrupting it in the middle. And COVID changed everything. And we won't even try to make the list of everything because it's so significant. We started out looking at needing to replace the emergency room in Clare, realizing what that would cost, and saying, why would we put a brand new emergency room and link it to a patient tower where there are not complete bathrooms and the rooms are still double? That's not contemporary either. And that's where Ray had gotten it to, of just saying, nope, there's no way to do this in parts and pieces. We need to do the whole thing. And we started working on that journey, and then COVID interrupted everything. But we did announce in July, we're going to expand and revitalize, and I'll explain what that means. We also announced that we're not changing any of our services. So no, we're not bringing obstetrics back, and I've already explained that. But we're also not eliminating any services. I mentioned earlier that to survive, some hospital systems are ending inpatient care, stopping surgeries, and really focusing on emergency care and primary care. We're not doing that. When we look at this community, we need a full service hospital, and that is what we are going to keep. We have now pegged the price tag. In today's dollars, it's going to cost us about $52 million to replace that hospital. By the time we're done, because this will take a few years to do, it will probably cost more than that because of inflation and things, but maybe building supplies will come down. And anybody think that's going to happen? That would be fantastic if it did. So we've also, in October, and the headline that I put up there for you is that we announced that we've hired the architect and designer. And they are bringing all new ideas to the table and looking at every possible way to make sure we spend as much of that budget as possible on clinical care and not infrastructure. So if we have to move utilities, or we have to relocate our tank farm, which is where we keep all of our med gases, it costs money, but it doesn't actually make the care better. It's just getting something out of the way. So we're working really hard to use that property as best we can, using the infrastructure that we have, and then building the clinical areas out as new. But it's not just about building a facility. As we have been working on this for years, and especially once we noticed and recognized the impact of the healthcare outcomes in this community, just building a building is not going to change the health status of this community. We need to be doing a lot more primary care. And I think we would all say that's a big deficit for us. We have struggled to have the right primary care providers in this county and constantly accessible. We've done a ton of work on that. But even more than that, we've got to reach those people who are not trying to get primary care. We have a huge population that just episodically goes to urgent care. We are diagnosing cancer in urgent care. That should never be happening. Urgent care is where you go on the weekend when you cut your hand doing yard work, right? Urgent care is where you go when you think you've got an ear infection. It's not where you go when you feel so crappy that you finally decided to do something about it, and we discover advanced diabetes, cancer, serious heart disease. We've got to get these folks into regular primary care relationships. That's huge. We do need an appropriate facility that can grow and evolve for us over generations now. And we also need to do a better job of telling our story. We are a not-for-profit hospital system, and a lot of people don't realize that. And what that means that we are doing to give back to the community is significant, and that we want to make this a healthier community, but we're going to need partners to do it. Those are important parts of our story, and that's as much of the work that we're doing as building the new facility. So this is an internal slide with lots and lots of detail on it, but it just shows you some of the work that's gone on, and it's really showing just the last year from June 22 to where we made our decision as a board and then announced it in July, but it's been years and years of research and study going on since then. I'm really fond of saying 2023 is not 2019. And what I mean by that is in 2019, we were living life was good, we had a certain way of doing things. And then we had this pandemic, and the pandemic's over now. So in 2023, are we doing things exactly the way we did them in 2019? No. Our society's changed, technology's moved on. In some ways, thanks to COVID, we've leveraged virtual technology so we can work from home. We certainly can provide a lot more care effectively and less expensively using virtual technology. The way we build buildings has changed. There's new technological advances there, so everything has changed. So we really had to look back and forward and try to figure out where are we headed now and what makes sense. Because frankly, in 2019, the way that you replaced hospitals was you built new ones. You found space, you spent the money, you built a new hospital. It was always fastest, and we had the money to do it, but it's much more expensive, especially when you're trying to operate a hospital while you're trying to build a new one. You can't just move everything from one hospital to another because everything you move has to be reinstalled and inspected. So you're looking at shutting down a hospital to build a new one. And we can't do that in today's environment, obviously. So we came out of COVID back into looking at this with this 2019 thinking and had to start reevaluating it. So what has changed? A ton of technology. We've talked about that. We heard very clearly the interest and desires of the Clare community on where they wanted their hospital to be. We were trying to figure out, is there a better place to put the hospital that makes it more accessible for everybody in this entire community? Farwell, Harrison, everybody. In the end, there really isn't. And I was really proud of a state police officer who was in one of our focus groups, because somebody said, you need to put it right dead center of the county. So it's equidistant between Harrison, Farwell, and Clare. And the state police officer said, you can't get to that spot in this county. There's no road. Phew. Because it all comes back to 127. As long as we're on the 127 corridor, that is the best possible access, because maybe it's distance, but time is less because we have a freeway to use. More than ever, we also recognize that the money we're investing in healthcare, medical centers, hospitals are greedy when it comes to the cost, but we need to be spending more and more in outpatient testing, in primary care. So how do we adjust what we're doing to allow for that? And then again, the cost realities. If I could give you a picture, I would say, think about when you looked at the images of Fort Myers after the hurricane went through, or Puerto Rico. Keep that in your head. Healthcare had a very delicate way of balancing our finances pre-pandemic. And the pandemic was like a hurricane roaring through. So if you could draw a cartoon of what our finances look like right now, they would look like Fort Myers right after the hurricane. It's a mess. We have to clean it up, and we have to figure out today, with the way things have changed, how do we make ends meet in healthcare? So all of those things and many, many more drove us back to looking at the current site that we're on. And for the first time, having architects and designers who said, you can stay where you are. You don't have a lot of room, but we know how to do it. And we can use the property that you have that still is undeveloped and use that to build out and expand. We can then knock things down, rebuild where they were, revitalize. I don't want anybody to think we're just going to put up wallpaper and flooring. We have to gut the place and completely revitalize it. And we're going to have a new hospital when we're done. And it is actually less expensive. And that's important to us right now as well. And I use a used car buying a car analogy. Most of us don't have the financial wherewithal to go just pick out a car on the lot, write a check, and drive off, and it's free and clear. We figure out, this is the car I want. How many years is it going to take me to pay off that car? So you chunk it out. Pre-pandemic, we had enough money that we could say, yep, we can afford to build a brand new hospital and we can pay for it in 18 months. We don't have that wherewithal now. We need to chunk it out. So by doing this where we are and in phases, it allows us to spend the budget that we have, but break it up over years. Hopefully not too many, probably 5, and we'll be able to afford the best value we can possibly deliver for this community in terms of healthcare. So that's what drove our decision. We won't go through this today. These are constraints that we had to work around, mainly because nobody thinks we've got room to do this. So especially with our staff, we had to explain, yes, we have room, and yes, there will still be parking when we're done. Between now and then, could get interesting, but it's going to work. So this is the last image I'm going to show you today, and it's a little hard to pick it out, but you see a great big kind of salmon shape. That's the largest footprint we can take the new hospital into. And within that salmon, there is a red line that is showing you the outline of the current hospital. It's an important image because, again, people keep saying to me, there is no way you have room. We actually do. And what we did to figure that out was we had to first figure out form follows function, right? So what are the services we're going to be offering? What volume to be forecast is going to be the demand on those services, and therefore how many square feet do we need to deliver those services? And lastly, can we fit them all into the property in a way that patient care flows well? So you don't want to have the emergency room and then imaging on the other side of the block, because then you can't get a patient quickly from a trauma bay to an MRI scanner and back again, for example. So it all fits and it all will flow. So conceptually, that's what we took back to our board of directors here for our region and to the executive team of the health system. And we all agreed, yes, we can do it here. It's going to work, and it's going to have a great outcome and great value for the community. So what's next? We got a ton of design to do, and we're working really hard on it. We have a lot of approvals. We ultimately will go to our health system finance committee, then our regional board of directors, and then our system board of directors. But if it all goes according to our timeline, we will be making parking a nightmare over there already this time next year. We'll probably start sometime in the summertime. So what I want to leave you with, and then we'll take questions, because I'm sure you have lots of them, is MyMichigan Medical Center today does not need improvements beyond the fact that the building is old. The people working in that facility are as skilled as any nurses, doctors, techs, pharmacists that you're going to find anywhere. Because a heart attack in Clare is not less serious than a heart attack in Grand Rapids or Michigan or Midland, right? A heart attack is a heart attack. So when you come to us, we may seem like a small town, we may seem rural healthcare, we have the ability to save your life and care for you beyond that, or get you to the advanced care that you need. The people are equivalent. The technology inside that building is equivalent to what you'd find in our facility in Mount Pleasant, in Alma, in Midland, and beyond. Only the facade is dated, and it does get in the way of our patient flow, especially if you go to the emergency room. But the people and the technology is what makes healthcare, not the building. So we need you to continue to rely on us to provide your care while we're going through construction. Please stick with us. Volume creates jobs, drives our economy here in Clare as well. It all is a flywheel. So please continue to trust us with your care. Know that you are getting exceptional care when you come to us, and hang in there with us through what will probably be some pretty disruptive construction. Questions? I know you must have questions. Yes.
Do you anticipate you'll be doing a capital campaign at all?
Yes. We have not set a goal yet, but we will be coming to the community and asking for support. Thank you for asking that question. Jerome?
If you begin, say, in the summer of next year, about how long is that expected to?
The conceptual design for the first couple of phases, which is emergency room, imaging, and inpatient, was about 2.5 years. I think when we're done designing with the actual architects, we're going to come up with something that is more compressed. Then we'll have phases beyond that, each that take about a year. So I kind of hesitate to talk too much about timing, because until we actually design it, and the faster we can design it, I'm going to talk out of both sides of my mouth. The more we can fit into early phases, the less expensive it will be and the faster it will go. But we still need to make sure we're not overspending in any given year. Other questions? Are you excited?
Yeah.
Yes, Tim.
I'm just so pleased with everything you're doing and how, exciting it is. But one thing that I think is another headline, and you have so many, and like you said, it could go on, but in the interest of time, I was so pleased to be invited and attend your open house this summer shortly before you made the announcement, and to learn about the 3 new physicians, and thanks to Ken Hibble for bringing them around and introducing them to a lot of us. Would you mind just touching briefly on that? Because
Absolutely.
That is a great story.
Yeah. So Paul Berg was the president of our MyMichigan medical group. He's since been promoted to CMO, but about the same time I got here, so late 2019, we really started looking at our lack of primary care access. And the main issue being that our physicians keep turning over. And there's valid reasons for that. But what we could control is we didn't feel like we were hiring the right profile of physician. We wanted to be intentional about people who really want to work in rural. Often you get people who have to pay loans back for medical school, and they have to go to an underserved area, but once they got those loans forgiven, they leave. And we needed to stop doing that. So instead, we started looking for really a needle in a haystack, looking for physicians who were training for rural and were from rural, so they understood rural. And in very short order, with that new profile, we hired 3, and they all started in August, except one had a baby. So she'll be back here in a couple of weeks. But 3 different programs, 3 different reasons, but all with local roots. One was going on for her master's in public health, awesome. So we know she gets it. We brought these 3 in, they all started together, and they're all in the Clare Medical Office building. At the same time, we also hired 2 nurse practitioners and put them in Harrison to open a walk-in service. Because we know, when I was talking earlier about some of the terrible things we're seeing in Clare urgent care, a lot of them are coming from the Harrison community. So if we can embed a walk-in service in the primary care health park there, get those patients going there, we have a better chance of having them become comfortable and engaged in a building and a set of people that they know and keep coming back. And the next thing they know, it's not really urgent care, they're in a primary care relationship, they just didn't see it coming. So those are some things we're really proud about, and we need to do more of those things. Thank you, Tim. What else? Oh, thank you, Don.
Can you define how far the patients come from in this region?
Ooh. Our region in total obviously serves Gratiot, Isabella, and Clare counties. We pull quite a bit from Midland County over towards Mount Pleasant and Alma. We pull quite a bit from Mecosta and Mount Calm. Not so much when you start getting west of Clare, but I think that's going to start changing because of the hospital closures and changes that are happening from other health systems to our west. We also admit, since we don't have admission service in Mount Pleasant, we direct our admissions from that Mount Pleasant emergency department to Clare or to Alma. So more and more people who are in Mount Pleasant ED that need an admission will come to Clare instead of going to Alma. We hold Alma's critical care capacity for those patients. So the diagram, the range is changing before our eyes. So that's about as close as I can get it right now. Other questions? Well, oh yes, thank you.
From Isabella County. My wife and I belong to the MyMichigan healthcare system. We used to be with McLaren, but all the doctors that we have came over to MyMichigan. I don't know if it's a plus or a negative to have two major healthcare providers in the Mount Pleasant community with McLaren and MyHealth. It'd be nice if there was some kind of consolidation. But I know you're in two different systems. You're both very dedicated.
Yeah.
Both are very dedicated to their patients. And,
Yeah.
But I just saying it's frustrating and kind of Mount Pleasant because I think we could do better if we had MyMichigan. McLaren would come over to MyMichigan. Just a thought.
I love it. Well, first I would say there's not, especially in rural, there's not a lot of competition in healthcare because the needs are so greater than the resources that we have anyway. So when we talk to McLaren all the time, we're saying that is we don't need to compete. We just need to take care of everybody we possibly can because we don't even have the resources to take care of all of the needs. But there's differences between the healthcare systems. So people will choose which system fits them better. And sometimes I think we waste resources that way. But that facility would be welcome if they would like to talk about something like that. So, what else? Well, I will stick around as long as anybody wants to talk. I know sometimes there's questions that you don't want to raise. Not everybody likes talking in big groups. So I will stick around. You also have my contact information, my personal cell phone number, and my email address. Please don't hesitate to reach out, and we will keep you informed as we move along here. Probably March-ish is probably when our next milestone will be that we'll be able to give you an update concretely on what's happening. Thank you so much.